everyone. Hi, good afternoon, everyone. Welcome to the Southern AIDS Coalition, Ending the HIV Epidemic. Where do we go from here? Where do we stand? We are joined by some federal agency workers and officials who are going to be briefing us on the current state of the things with the plan that's going on with the Ending the Epidemic, and we're really excited to have them. My name is Christina Adeleke. I am the Policy and Communications Manager at the North Carolina AIDS Action Network. Today we're joined by Harold Phillips, Dr. Maureen Goodenow, Chrissy Abrahms, and then Ayers. We will likely go in that order, and we'll give each of our panelists a few minutes to introduce themselves, tell you where they work, and just give a brief highlight, and then we'll go into some Q&A questions. So we'll go ahead and start with Harold.
Hello, everyone. My name is Harold Phillips. Thank you, Christina, and thank you to the Southern AIDS Coalition for inviting us today. I'm here as the Chief Operating Officer and Senior HIV Advisor for the Ending the HIV Epidemic Initiative in the Office of the Assistant Secretary for Health. So in that role, I am responsible for working across and coordinating with our federal agencies at HHS, as well as for moving forward the Ending the HIV Epidemic Initiative, which is the bold initiative to end HIV in the United States within the next 10 years, which is bringing us from just over 38,000 new transmissions to 3,000 or less within 10 years. So in my role in working with our HHS partners, I'm also responsible for helping to ensure that all sectors of society are aware of the initiative, that we have broad community engagement, and that the voices of those on the local level are being taken into consideration as we look for innovative approaches to try to end the HIV epidemic. It's a recognition that the systems that we have successfully built over the last 30 years, we've had a lot of incredible gains, and that HIV, due to the science and the medicine and the policy and the research that has been done around implementation, as well as the scientific on the medications, has allowed us to be at a point in our history where HIV is no longer a death sentence. If we can provide access to medications, get folks into treatment early, and also the work that has gone into preventing HIV with PrEP, and also what we know about syringe services programs and behavior change and the impact of social determinants of health, which can put individuals at risk for HIV transmission as well. So combined with all of that, applying the science, applying what we know, moving in a different direction, and knowing that there are still those that we have not reached, and pushing for innovation is the job that I have. In addition to that, with the HHS agencies, we are also responsible for this iteration of the National HIV Strategic Plan, which will come out later this year, which calls for working across the federal government as well as at the state and local level, again, in alignment with our goals of ending the HIV epidemic. So I think with that, I'll stop for now.
Yes, we'll have plenty of time to hear from you later. We'll pass it off to Chrissy Abrahms.
Hi, and good afternoon, everyone. My name is Chrissy Abrahms Woodland, and I am the director for the Division of Metropolitan HIV/AIDS Programs in the HIV/AIDS Bureau within Health Resources and Services Administration. I know that was a mouthful. So just to give you a quick overview of, first, my division monitors the Ryan White HIV/AIDS Part A program, which is also the program that also received funding for 39 of the EHE jurisdictions as well. But just an overview of our program. So as you know, or may not know, the Ryan White HIV/AIDS program provides a comprehensive system of primary care, HIV primary medical care, and essential support services and medications for low-income people with HIV. So our program funds grants to states, cities, counties, and local community-based organizations to provide care and treatment services for, to people with HIV. In addition, we do support some clinician training, technical assistance, and the development and dissemination of innovative models of care to improve health outcomes and reduce HIV transmission. So now as it pertains to HRSA and HAB and EHE, and this past winter, HRSA did award approximately $117 million to the Ryan White HIV/AIDS program, as well as our HRSA-funded health center program under the EHE initiative to expand access to HIV care, treatment, medication, and prevention services. And so this investment is a critical component of the EHE initiative overall. So within the EHE initiative, our HRSA's HAB is leading Pillar 2, which is the treat pillar. And we're focusing on linking people with HIV who are either newly diagnosed or diagnosed but currently not in care into our services, as well as focusing on those not virally suppressed. So I will, I think we'll pass it on in terms of just giving a brief overview of HRSA, HAB, and our program and our role with EHE. Thank you.
Thank you, Chrissy. That was important that you made that distinction. We'll probably talk more about that later with HRSA and the CDC and all of that and everyone's role in the EHE plan. Let's pass it to Maureen. Maureen, I think you may be on mute.
Thank you.
Yes.
So I'm the Associate Director for AIDS Research at the National Institutes of Health in the Office of the NIH Director, and I'm also the Director of the Office of AIDS Research. I put together some slides, which I will go through quickly, and also hopefully there's some way to disseminate the slides afterwards if people are interested in them, and that's mostly why we're showing these. But if we can go to the first move, are you going to change the slides for me? Yeah, okay. So I was going to start and just let you know about what the Office of AIDS Research does. It was established in 1988 as part of the National Institutes of Health, and the reason for setting it up was to establish a way to coordinate all of the HIV-related activities that go into the research portfolio at the NIH. In the next slide, I can show you the interdigitation and the intersection between the NIH HIV research program and the strategic goals on the left. And you can see how they encompass through rigorous, advancing rigorous and innovative research, ensuring flexibility and responsiveness in the research program, promote dissemination and implementation of discoveries, and build human resources, and how this interdigitates with the 4 pillars of ending the HIV epidemic in the United States. In the next slide, this slide illustrates how the research enterprise and how the research pipeline develops from very basic research on the left to implementing public health and policy on the right. And the NIH functions very much in the basic clinical translational arena, developing new strategies, coordinating activities, engaging stakeholders, and the products from the NIH research program are really the products and the information that our federal partners use in providing treatment, prevention, and care in the public health setting. And in the next slide, this just gives an overview of all of the options that have been developed in the last 30 years that fall into the HIV prevention toolbox. And so we're continually developing new discoveries that can be translated into new products and new methods that will help prevent and treat people with HIV. And in the next slide, the interdigitation between the NIH research agenda in general, HIV research agenda in general, and ending the HIV epidemic in the United States is showing here as an overview of the Centers for AIDS Research and the AIDS Research Centers that are really the key hubs for quickly and actively getting supplemental funds out to investigators, not only at the academic institutions, but where the research in many cases is being carried out, which is in the rural South and in a large number of cases with the supplements that have been funded so far. Almost half of the supplements from 2020 are for research projects in southern states in the United States. And the next slide. It's obviously hard to talk about research, particularly in the area of HIV, under the current circumstances without talking about COVID-19. And what we're showing here on the right is the distribution of HIV prevalence in the United States. And on the left, you can see the prevalence of COVID-19 infections. And as we now know, there's a lot of geographical overlap in these two epidemics, these two pandemics, and not only in the geographic, but also in a lot of the structural issues dealing with health disparities. And in the next slide, there are some ways to stay connected with the OER. Thank you.
Thank you, Maureen. Thank you for sharing. I think, the times that we're in, especially with COVID-19, it's particularly challenging to remember the work that we were doing, how all of that fits together. And I hope that we'll be able to have a little bit more time to talk about that. Hopefully find opportunities for synergy. Hopefully opportunities for growth. But before that, we're going to hear from Ben. Go ahead and share what you have to say, and then we'll get into it.
Hi, everyone. Benjamin Ayers here. I'm the deputy in the Office of HIV/AIDS Housing, which administers the HOPA program, which is housing opportunities for low-income people with HIV and AIDS. And our office is really, our mission focused is to provide states and cities with those incentives that they need in order to devise really long-term strategies to address the housing needs of low-income people living with HIV and AIDS, but also in a way that's free from discrimination. We've been working toward elevating housing as a structural intervention to ending the AIDS epidemic over the past several years. And my role in the office, I kind of am responsible for reviewing and providing feedback, and I'm the first line supervisor there on all the products and tools and communication pieces that we put out there. I know Rita Harcrow, our director, could not make it today. She wanted to have me say as well as how she's excited about this EHE initiative. And as a person living with HIV, I would like to say as well that, this EHE initiative, I have to say, is probably one of the best things to come out of this administration. And I'm super excited about all the work that's going on with it.
Thank you so much, Ben, for sharing. All right, so what we're gonna do, I'm gonna structure the questions and kind of think about the first section of it being the past year, kind of focusing on each individual agency and what your focus has been over the past year. And then we'll kind of focus on COVID-19 and think about the impact that has had on your agency's work. And then we'll talk about plans moving forward, what you hope to see, what potential political changes and that impact that it may have on the EHE plan. So we'll kind of go on a journey in time. So now we'll go back. Let's go to the past and think all the way to last year. And I would love to hear from each of you all what your agency's focus has been when it comes to the EHE plan, specifically when it comes to the work that impacts the South. And you can provide some highlights, and then you can also think about some areas where you feel like you would have liked to had more opportunity. You would like to be able to move forward on some things and maybe some areas of improvement. So we'll go back and start with Harold.
Okay. Thanks, Christina, for that question. And I'll do two things in trying to respond, both talk about the role of the Office of the Assistant Secretary, but also talk about some of the work that was done with the Centers for Disease Control, which isn't with us today on the panel, but they are also a key federal agency in this work. And also our partners at SAMHSA are not here with us, or Indian Health Services, who also are part of the HHS agencies that are involved in the Ending the HIV Epidemic initiative. So when the initiative was announced on February 2019, the federal agencies and partners spent a lot of time going to different parts of the country, including the South, to do listening sessions and hear from the community about both the successes in HIV prevention, care, and treatment, as well as what some of the challenges are. And some of what they heard was not surprising, especially given what we've learned today about social determinants of health, coexisting conditions, their impact on minority communities, the impact on the South. And one of the things that the federal agencies really stressed was the need for locally driven solutions that both sort of picked up from the science, as Maureen talked about, sort of the research agenda, the implementation science, taking what we know works best when it comes to both prevention, care, and treatment, and then how do we tailor it specifically to be able to meet specific community needs and the needs of certain populations across the country. Because we all know from doing this for so long that what necessarily works in Detroit might not work in Jackson, Mississippi. And so we need the folks in Jackson, Mississippi to tell us what will work, what needs to be changed, and what needs to be tweaked, but still being sort of science-based and having that science at the core. So we spent a lot of time in doing that this first year. We also spent a lot of time in just telling people and making sure that there was an understanding that this could be done in the United States, that we had the tools, we had the capability, and that we needed to apply it in the right way. Many people have asked, is that true? Could you really do that? And I have said, because I had the privilege of being able to do global HIV work for 5 years in my previous role, I saw us do it in countries in Africa with infrastructure that was worse than some of the infrastructure that we have in the United States. I saw us do it in places where there were healthcare worker shortages, where there were sometimes 8 different local languages that needed to be considered in the provision of services. So yes, we did it in those countries, and we did it using US taxpayer dollars, but we did it because we applied the science, we applied the tools, and there was a political will to come together and to work together with the community to get it done. So I know it can be done. So part of my job over this past year has been trying to drum up enthusiasm and energy and getting that understanding out there as well. And then our colleagues at CDC have been doing similar things, but focusing on both prevention and the diagnosis pillars of EHE. How do we scale up testing in non-traditional settings, such as emergency rooms, homeless shelters, substance use treatments? And so, so there's been that work that has been going on, STI clinics as well. So how do we do that piece of it, as well as the work of OASH coordinating across the federal agencies? So I'll kind of stop there.
No, you brought up a lot of great points. I mean, I think when it comes to, one, for sure, collaborating amongst government agencies, I know that that's been a concern that I've heard from community members, just wondering why certain parties weren't at the table and all of that. And I'm glad that, I'm happy to see Ben here and to see, that SAMHSA is a part of these conversations. And another thing that you brought up that was super important was the focus on the social determinants of health. And that's come up, in a couple of comments earlier, but that's something that, like you said earlier, is not new. And, we also know that there's such a huge, not addressing those needs serves as a huge barrier to addressing HIV. Yet, with these plans that are currently, in process, I haven't seen a lot of allocation of funds to address those needs, but it's always like a part of the conversation.
Right.
How we would be able to move forward if we don't address those needs. And that's something that community members have brought up.
Right. So one of the things that our Assistant Secretary for Health, Brett Gerard, heard through the listening sessions was the importance and the impact of housing and housing status on health outcomes for people living with HIV, but also how housing status puts individuals at risk for HIV because of things they have to do in terms of coping mechanisms in order to just survive and make it through. That might put them at risk for HIV. And so as a result of that, one of the first things I was asked to do was figure out how to bring our partners at HUD into sort of the realm and also help make that community more aware of EHE. And so it was as simple as, because of the relationships that I have with Ben and Rita and their team, it was as simple as walking down the street from HHS headquarters and saying, hey, you guys, we really need to talk about this. And we spent, several meetings talking about EHE, the need for the HIV housing community to even know more about the plans that we were developing, how they could get involved. And then also, how do we make the EHE jurisdictions more aware of the resources that HUD already had in the community so that we could understand where the gaps are. And I think that the housing resource tool that helps, that we released a couple weeks ago, maybe that was a month ago, Ben, to help jurisdictions understand the resources that are already there so they can look at where are the gaps as they plan for the future in using the EHE resources to fill in any of those housing gaps. So I don't know if you want Ben to say a little bit more about that, but that was a huge, heavy lift this first year, and we released it probably about 4 weeks ago.
Yes, I would actually love to transition over to Ben to be able to kind of piggyback off of that, and just to talk about housing and its importance in this plan.
Yeah, so I'll just start out by saying too, again, thank you again for the opportunity to participate in this important panel discussion. Over the past year, we're not really funded at the federal level. HUD really isn't specifically funded for the EHE initiative. However, we've really been coordinating with EHE leadership at HRSA to think through and kind of develop, as Harold was saying, what our role would look like in EHE. And so right now, HUD's partnership with HRSA is really focusing on the coordination of existing HOPWA, as well as other HUD resources for housing and supportive services in the EHE communities. And then also trying to make connections locally between the EHE planners and the housing providers. And so to that end, as Harold was referring to, our office developed and provided this tool for HHS staff and EHE jurisdiction planners to help them really to help the EHE jurisdictions really understand where the HOPWA resources currently are in place and better understand how and where they can collaborate with our HOPWA programs and make those connections with our grantees and subrecipients in order to coordinate housing and service resources within the EHE jurisdiction. And so if you could, Anna, pull up that tool as just a quick snapshot for everyone. This is just a visual tool, no need to read through it, but the tool itself provides, the different funding levels and funding projections for our grantees in the EHE jurisdictions, as well as links to their performance profiles, how they're doing in providing housing stability in each of those EHE jurisdictions, as well as the activities that they're providing, the contact information for each of the HOPWA providers in those jurisdictions, and then a mapping of the EHE jurisdiction counties and how they fit within our HOPWA grantee service areas. And I just kind of want to piggyback on what Harold was saying is that, one of the main social determinants of health is housing. And so, as we've been, more engaged in the EHE role, it's been pretty clear, that, we're not going to end the epidemic in the U.S. without housing. And our HOPWA community really does need to be engaged in these efforts at the local level. And so for housing, it's really hard for someone without housing to even engage in care. It can be done, but it is very difficult. Folks who don't have housing are more concerned with, where they're going to lay their head at night, where they're going to sleep, where they're going to get their next meal from. And as well as, some medications require, different foods at different times taken at the same time. You need consistent health care, which is all very challenging to do and participate in without housing.
Absolutely. Totally agree. Let's transition over to Chrissy. I know with your work with HRSA and HRSA, it's a complicated situation. So you may not be as involved in the EHE plan, or are you? And I'd love to hear about what your work is like in this time.
So as Harold mentioned, so the overall EHE plan is an activity that's funded by CDC. So that wasn't a direct HRSA funded program or activity, I should say. But as Harold also mentioned about the collaboration and us increasing our collaboration amongst the federal agencies and partners for EHE, we have been in constant communication with our CDC colleagues. We actually partnered on the review of the draft plans when they initially came in, and we'll do the same when the final plans are in as well. So in the Ryan White program, we do not have direct oversight of the larger EHE plan. But our funded jurisdictions were, they did submit to us a work plan for their Ryan White funded EHE cooperative agreement that discusses what they will do at their jurisdiction, at the jurisdiction level to address ending the HIV epidemic and the activities that they will specifically implement. And of course, what they are proposing to do should feed into that overall ending the HIV epidemic plan. So what we're doing on our level is it feeds into the larger plan, but it's more specific to our Ryan White program and those are the jurisdictions. So in terms of answering the initial question about what we've been doing over the past year, actually Harold just highlighted it and kind of gave the whole rundown on the series of community engagement sessions that we conducted across the country last summer and into the fall. So we did about 20 actually in the South. And that included cities like Jackson, Mississippi, Houston, Texas, Austin, Texas, Columbia, South Carolina, Atlanta, Georgia, Birmingham, Alabama, Miami, Florida, Little Rock, Arkansas, Memphis, Tennessee, Oklahoma City, and New Orleans, Louisiana. So we did make our rounds, over the past year in these community listening sections and engagements. And as Harold highlighted, those challenges that we heard, what came out of that was, addressing the mental health, the substance use, the incarceration, transportation, and definitely the homelessness. Also addressing stigma, health education, and criminalization laws. And so also just talking about the workforce shortages of medical providers and behavioral health providers as well. So we also heard some strategies, as Harold mentioned, about what can help us to meet our goals and just ensuring that meaningful community involvement in the planning for EHE activities and identifying and, including new partners and, identifying and hiring the community health workers as peers and bringing them to the table as well. So we did gather a lot of information from those community engagement sessions. And, we also heard how important it is to allow jurisdictions to be innovative and to adapt and adjust as we learn. And so those are all the things that we did try to take into account as we were writing and developing our EHE program for the Ryan White HIV/AIDS program. And I know you had initially asked a question about maybe some of the areas that we wish we had maybe hoped to have accomplished or where we are. So yes, we had much progress in addressing some of the health disparities and viral suppression across all of our key populations in our Ryan White program. However, as we just started, we were talking about, we still have a persistent disparity among the Ryan-White clients who are unstably housed. So that definitely remains to be a challenge for us. So while viral suppression has improved, there is still the same percent point gap in that population between 2010 and 2018. So that is an area that we are definitely looking to focus on, which is why the partnership with HUD and HOPWA was so integral. And yes, those the tool that Ben and Harold were just mentioning, we are partnering with them. We disseminated those tools to each of our EHE jurisdictions to ensure that they had this information. We also made our project officers aware of it because we want to maximize our resources. And as we know, housing is a severe need. We want to ensure we're tapping into every resource possible as we're looking at funding and services that are being provided throughout the jurisdictions. So we are partnering with our federal entities, and that partnership will continue to grow, and we will continue to work together as one initiative, because, you know, while we all have like certain priorities or leading certain areas, this will not work if we're not all at the same table. So I always look at the initiative as puzzle pieces. Those 4 pillars are puzzle pieces, and they all have to fit together. And so just with Dr. Goodenow and the NIH and the CFARS, we're looking to really tap into that resource as well in terms of just providing those resources, those evidence-based practices that could help move our jurisdictions along into ending the epidemic in their areas. So lots of collaboration coming ahead of us as we've started, but we need to continue, and we do have a lot of work ahead of us. We still have to address, you know, a lot of underlying challenges such as stigma and homophobia and transphobia and racism that lead to system level and provider level and personal challenges. So there's a lot that we have to do and focus on to be culturally responsive and patient-centered and taking that overall trauma-informed approach. But definitely understanding those social determinants of health and prioritizing them, and also looking at, as Ben was alluding to, about the housing piece. You know, we have to address the individual's priorities, and they're managing their HIV may not be their priority if they don't have a roof over their head or don't have food to eat. And so we have to look at treating the whole person. And so that's really the approach that we are taking, and really encouraging our jurisdictions and our recipients to take, so that we can end this epidemic.
Yes, absolutely. You know, it's hard to move forward on a lot of these things because, you know, it does take resources. And I feel like, you know, there are resources that are allocated to this plan, and it's really great. But, you know, when it comes to addressing housing, and there was a question that did come up in the chat, you know, if the administration was going to be pushing for additional HUD funding, because that hasn't been included before. And just thinking, like, you know, if we want to include these you know, tenants in the plan, we're being responsible as possible with the resources already given. You know, that still hasn't been enough. So we'll hopefully, you know, have more time to answer that. But I'd like to get to Maureen just to talk about, you know, your past year in the plan and what that's been like. And then we'll switch over to COVID and how that's impacted the work.
Sure. So similar to some of our other partners, we were, you know, as soon as this announcement of the EHE came out in February of 2019, at the NIH, we collected together and really started to identify where we could jumpstart the program, because the funding, as you know, really didn't start until 2020. And because of the infrastructure with the CFARS and the ARCs through National Institute of Mental Health and National Institute of Allergy and Infectious Diseases, and because they had structure set up, we were able to quickly develop plans and find some resources to start to fund supplements. And we particularly were looking to catalyze moving research from the specific location of the academic centers out into the communities, and to have the investigators really start to make either build on relationships that had already been established, or start to build new relationships, so that we could, as my colleagues have already mentioned, that we could find out whether or not what they wanted to try was going to work in that particular jurisdiction or that location. And I think that's part of how the interaction has developed across the agencies in a very iterative process. And the faster we can get the information, the faster, you know, we can do our part and push the information out and continue this, you know, development, which is very, very exciting. I think one of the recurring themes has been over the last year and a half is really how much the federal partners are working together. And I think it's palpable. And I haven't been at the NIH that long, but just in the, you know, pre-EHE and post-EHE, the amount of interactions and collaborations have increased exponentially. I think the other things that we were also at the NIH and OAR in the process of doing listening sessions around the country to try to get input into our strategic planning and prioritization. And so a lot of those, as you can imagine, evolved into EHE sessions. But I think somewhat different communities than perhaps some of the of our other federal partners. So we had academics, we had a lot of community board people, people who were involved in the clinical trial networks as advisors or as participants or as investigators. And a lot of what we heard coincided with what other sectors were hearing, but then there's also some of the unique aspects, as you might expect, particularly keeping open the pipeline and increasing the pipeline of young investigators in the field. How are we going to keep people interested in doing HIV research and coming into that field? So there's, you know, some of the issues were similar, and then there were some specific ones. I think that, you know, the issue of whether or not this can work, I think I just want to point out this amazing story in the Washington Post this morning in the Metro Center, the Metro section, about DC announcing a 16% in new HIV infections in 2019. And that was really a pre-EHE, and that is an amazing number, and it reflects what communities can do and the kind of impact that this work can have. And then I think one other thing too, that in the past year for us, it's been really exciting, is the very positive results that came out from the Prevention Trials Network, what's called the Protocol 083, that showed the efficacy of long-acting cabotegravir for prevention of HIV infection. And we're very excited about that result. We're looking forward the end of this year to see the results from the parallel trial in South Africa, looking at the long-acting cabotegravir in women in South Africa. So that, as that moves forward, I think that has the potential over the next 2 or 3 years for being a huge game changer, and really something that our partners can implement and help your part of this project as well.
It's so nice to hear that women are involved in these trials. That seems to be something that a lot of community members have been asking for. So that's great to hear. And I agree that will be a game changer as well. There is a question that came up that I think is relevant to the conversations that we've been having about community engagement. There's a question asking if there is a report or summary of the findings of these listening sessions that can be made available. Because I know that, you know, in some members that I've talked to, they weren't even aware of the meetings or the listening sessions. And I'm not entirely sure like who was invited and how that all went down. But I do think it would be helpful for community members who weren't able to attend to be able to hear or read what was discussed. So are those available? I'm not sure who has the answer to that.
The ones
Right.
from the NIH, yes, we actually are in the process of and have a first draft of a interim report. We're continuing these listening sessions. We had several scheduled that had to be put on hold because of COVID, but we're reactivating them virtually. And yes, we definitely will have a report coming out about what we heard and what we're planning to do.
Harold?
So from the OASH level, there currently is not a report, but there are sort of a summary of some of the findings and the major themes, like Chrissy talked about some of the issues around stigma and transportation and mental health, the need for trauma-informed care, housing, of course. So there is not a formal written report. This is probably about the second time I've been asked about whether or not there could be something like that. So I think what we'll have to do is go back and see if working in collaboration with the agencies that were part of those listening sessions, because all of those happened before I was on board as well. Maybe we can do sort of a summary as part of our first year wrap up of EHE events.
And also on the listening sessions, I know that Maureen mentioned that they're going to be ongoing. Do the rest of the agencies anticipate additional listening sessions, perhaps to see if, what's been implemented so far has been effective, and just kind of, thinking if we need a course correct or some sort of follow-up?
We're in the process now of having some conversations about the need to continue to have virtual community meetings around the EHE. Like COVID really threw a wrench into everything. I would say that personally, prior to COVID, I was probably on the road about two weeks out of the month, going to different cities, both doing EHE meetings. We were also deep into the planning process for many communities at that time as well. So there was a lot that was happening across the country, and we were trying to reach as many communities as possible. I'd run into Maureen in the airport, just sort of like changing planes from time to time. And so we had plans to get Ben and Rita and HUD out there. We were practically going to live in some parts of the South, given some of the housing issues and concerns. And then, we got put on lockdown. But now really thinking about it and hearing from a number of groups that they still feel the need to have the guidance from the federal level, and also the need to ensure that things are being carried out and that our messages are being delivered by some in the jurisdiction leadership. I think we do need to double back and think about virtual meetings and how we might use some of these platforms to continue to get those messages out.
Excellent, excellent. I do want to piggyback off what you were saying about COVID-19, because I know that that's definitely impacted the implementation of this plan and everyone's work. So I'd love to hear, I'll give you a break. We'll go to Chrissy next and just hear how COVID-19 has impacted the work, and if there are opportunities for synergy to address COVID and ending the HIV epidemic.
Yeah, so of course, definitely COVID has had an impact. So some of our Ryan White programs, the work has been delayed, and as state and local health departments and had to redeploy staffing and space in the response to the COVID efforts. So we have seen some capacity changes at our recipient level. And then we know many of our Ryan White program providers are working on the front lines. So they're in their communities and serving the most vulnerable populations. And so we do recognize that, again, just the burden of responding to COVID and the impact it has had on our jurisdictions. So although the COVID pandemic has disrupted some normal operations, it has also forced us to find new ways to do our work. And so there were so many lessons learned and innovations that can accelerate our work, right, to meet the challenges of EHE. And so, for example, telemedicine. So we're hearing, and it's so exciting that, just in this short amount of time, it's shown that to reach those that were out of care, improve retention rates. And, although we need to remain vigilant around that whole digital divide aspect, which could increase some disparities, we have seen some promising results with the telemedicine. Also, just better continuity of, to access to medications with the extension of the 90-day medication refills and the increased home delivery. These are all things that definitely feed into EHE, as well as the accelerated self-testing for HIV and STIs, and then also more specific to our Ryan White program, is just the streamlined eligibility and recertification processes. So all of these, will carry forward in the Ryan White programs and the EHE work. And so we are, looking forward to some of those lessons learned and those innovations that we were kind of forced into due to COVID, but that have proven to be successful and helpful as we move forward in ending the HIV epidemic, to ensure that we carry those forward as well.
Excellent. Ben, let's hear from you.
Yeah, so I would just ditto everything everyone was just talking about. I think we'd all hope that we'd been a little bit further along in the planning phase and the partnership building from the HOPWA perspective anyway in the initiative. But again, when the pandemic hit, we had to shift those priorities, and the EHE work was forced to slow down a bit, which even prevented the progression of rolling out the HOPWA planning tool to the EHE jurisdiction planners. And so I kind of would just like to note, across all the departments, I think that we've all been pretty, acutely aware of the crisis that the communities are suffering right now. And as important as the EHE work is, it's even been a part of the EHE leadership discussion that, we had an immediate need to shift focus over onto addressing COVID-19 needs. As far as how it really affected us in that slowdown, I would say, the HOPWA program did receive an appropriation from the CARES Act for COVID. And so again, we had to shift our focus to getting that money out the door at the same time as our regular 2020 appropriations. These CARES Act funding came with a lot of flexibilities that our regular HOPWA funding didn't have. And so in addition to getting the money out the door, we had to develop and implement like a technical assistance strategy to really ensure that the grantees understood the different ways that this funding could be used and how it can be coordinated with regular HOPWA resources, as well as those CARES Act resources under Ryan White and the other HUD programs receiving CARES Act funding in order to address the housing and service needs of households affected by the pandemic. All of this effort is currently still ongoing. I would say, again, like everyone else, our office has been trying to carry out the CARES Act work, as well as the EHE and kind of everything else from home. And so it means that, we've not been able to really travel and engage in those traditional ways with some of our HOPWA and EHE communities. And so we are kind of looking forward to, when we can shift focus back to EHE and really kind of dive in there and come up with those inventive ways to become engaged remotely and virtually.
And if I could, Christina, because I also feel like sometimes HOPWA isn't given enough credit for the work that they did really quickly during COVID-19 to ensure that people living with HIV and facing homelessness were put in homes, were put in hotels, had access to hand washing facilities through the CARES Act. And it was, I saw it on the streets of DC, just how quickly things were shifting to ensure that population was not completely ignored. And so they are a very small team that did tremendous work during that time. And I don't think that they necessarily get enough credit for some of what they were able to accomplish, because it was truly amazing to see it happen real time for people at risk of homelessness, people who were homeless, people who, faced being evicted, all of that sort of stopped. So thank them.
Thank you, Harold. And just to give folks an idea of how small our staff is, there's Rita, the director, and I'm her deputy, and then we have just nine program staff, and that is the staff that runs and operates the HOPWA program across the nation. So,
wow, that's wild. That's wild. Harold, I completely agree with you. I think HOPWA doesn't get enough credit. I think they're doing a very important work to keep people alive and in treatment. I'm curious to know from Chrissy and Ben, has the Ryan White program and or HOPWA seen an uptick in participants as a result of COVID, or is that not been impacted yet?
We have at Hopwell, yeah, we've seen an additional need, especially for quarantine of hotel motel, including some of that flexibility was able to use for people who were not HIV positive, in the family, to be able to utilize funding to help them get quarantined as well. And so we've had grantees, especially under our competitive program, who have already notified us that they're going to run out of funding or run out of money in a couple months. And so we've definitely seen an uptick in need for those resources that are being implemented, and the use of that funding, getting it out the door.
Yes, and I agree. And actually, just last week at our national conference, we had some of our recipients actually report out and present on the use of those HOPWA funds in addressing the housing needs during this COVID pandemic. And so there has been a definite increase in need in our jurisdictions. Our Brian White Part A recipients have been very creative in terms of trying to meet those needs with their current budgets and their service. We too did receive some CARES Act funding, which allowed some greater flexibility so jurisdictions can address it as well. And to that extent too, HOPWA and HRSA has been collaborating on the use of the CARES Act funding as well. And so we've been developing a crosswalk, just trying to so we can assist our jurisdictions and again, maximize those resources. This is what's available. How can we maximize our resources to reach as many people as we can and to ensure maximum impact? So we have been definitely increasing our collaboration throughout this time. So not just around EHE, but around COVID as well. And again, as Ben said, it slowed us a little bit, but we will continue to beef that up and continue to collaborate, as Harold also says, as our leader of EHE, pulling us all together and keeping us, moving on the right track.
So true. I feel like buzzwords that I've been hearing during this session that have been important have been flexibility, whether it be flexibility with funds or arbitrary rules or whatever, and then collaboration. That's another one that I'm like, if we all did that, that makes a lot more sense. It's great that we're seeing great outcomes coming as a result of that. Maureen, let's hear from you. How has COVID-19 impacted the work at the NIH? Has it just increased the work? Are we juggling a bunch of different balls at the same time? What is that looking like?
All of the above. But let me explain. There's some positive things that have come out. I mean, the HIV research programs and infrastructure have really been integrated well into the COVID initiative. The early trials testing vaccines already are building on some of the vaccine trial networks that were put together at the NIH for HIV. So there's a real synergy, I would say, there in terms of actually HIV field being able to jumpstart all of the really exciting COVID research, not only for vaccines, but also for therapeutics and for new diagnostics. That's something that I'm also very excited about because I think that I'm very excited about a lot of these new platforms that we're getting to have little insights into and different approaches that people are using in different areas. And I'm very excited to see what they come out with ultimately for diagnostics for COVID that we could potentially import into the HIV field to streamline and diversify the way we do testing, the way we do diagnosis, and the way we monitor whether or not the therapies are maintaining viral suppression. So I think those are very positive outcomes. On the other side, we have to realize that basically non-COVID research in the physical workspace, meaning in laboratories, has been basically shut down, not only at the NIH, but virtually across the United States in all the academic institutions. And while some of these are rebuilding, starting to build up, reopening the physical workspace, and while people were not in the physical workspace didn't mean they weren't working, because I know people always have lots of data and papers to write, and so there was almost an interlude where you could kind of catch up, but it's been 6 months and labs need to get opened, and it's really a big challenge. There are challenges not only in terms of physically opening the workspace and how do you maintain social distancing and space, but also how are we going to fund the research recovery, if you will. Reagents have gone out of, have expired. Some reagents are not available right now. The pipeline of non-human primates is being, their needs for non-human primates for the COVID research development. So there's a lot of implications for HIV research going forward, maintaining the pipeline of young investigators. Some institutions are questioning whether they should have graduate programs next year. Should they just put a moratorium on bringing in new students or taking new postdocs? So all of this is going to have a big long-term impact on HIV research.
So true, so true. All right, we have 5 minutes. We're gonna go into the Q&A and pull some questions from here. All right, this is another one related to buzzwords. What is innovation shaping up to be so far? I know that's a term that we've used a lot in the EHE planning process. How has each of y'all's agencies seen innovation pop up? We can start with Harold.
Okay, I'll start, and then maybe Chrissy will jump in on this one. But some of the innovations I have seen involve new partnerships, especially given COVID-19. Our HIV sort of resources can't do this all by themselves. So we need partnerships with the Department of Transportation. We need to be able to address food insecurity. So we need programs from the Department of Agriculture, both federal and local, to do this. I have frequently said that we cannot solve this just on the back of the HOPWA program. So we need HUD and the complete array of housing resources that are there, from public housing to Section 8. We need all of them to be on board to help us. So it's partnerships like that, partnerships with the criminal justice entities, and sort of dealing with that pipeline from jail to HIV care as well. So that's what I would say. Those are the pieces where I've seen innovation and communities coming together and bringing those programs to the table.
Chrissy?
Yes, and that would just piggyback off of what Harold said. So we're seeing exactly the same thing in terms of, like, and as I mentioned earlier too, just around COVID, some of those innovations around telemedicine and, streamlining processes within the programs and coming up with new ways to do things. And so we've really been pushing our jurisdictions and our recipients to really think outside the box, to think outside the scope of your current Ryan White program, because now you have more flexibility with your EHE initiative funding. So what can you do differently? How can you do it differently? How can we reach the populations that we have not been able to reach? So yes, we have great viral suppression rate of 87%, but we need to reach the 13. So, focusing on that and how can we be creative in reaching those populations and just thinking outside the box. So we've just really been pushing our jurisdictions and our recipients to think beyond what you're currently doing in your Ryan White program and take it a step further. So, and as Harold mentioned, bring those new people to the table. So it is so important to engage new stakeholders. This community engagement piece is major in terms of the EHE being successful. So we have to engage the people and have everyone at the table who can have impact and make a difference. And so that's what we've really been pushing from our end. And again, we're seeing our jurisdictions now starting to think outside that box and figure out how to streamline processes, how to make things easier, and how to start thinking about reaching those populations in a way they haven't in the past.
What are those efforts looking like? Because that's a question that came up. The listening sessions were very low in attendance here in Arkansas, and I'm curious to know how the National Committee plans on engaging the overall local communities where these critical issues are affected. So, what creative ways are going to be implemented to be able to engage the community, like you said, in a meaningful way?
So one of the things that happened, when the initial plans were sent in last December, CDC, HRSA, and our office, Office of Infectious Disease Policy, did a review of those plans. Once we looked at those plans and reviewed them, we gave each of the jurisdictions feedback on what we saw, what we didn't see, what we expected to see, what needed to be in there. And they have until December 31st to revise those plans and get them back to us for another round of reviews. I think, you know, those of us at the federal level, we are aware of what the epidemiology looks like for HIV within these communities. Having heard from some of you all, having looked at over a number of years, some of the needs assessment, we kind of have a sense of who needs to be at the table and who needs to be represented and what some of those potential solutions are. So I think between our technical assistance networks that include the technical assistance for EHE, the SIBA providers, the AIDS education and training centers, and the expertise that exists on the federal level, we will be working to help, I think, move the needle when it comes to EHE and the eventual goals. The other piece that I will say of what it looks like, if you have a jurisdiction that is not currently working on data sharing agreements so that there can be greater collaboration and partnership between healthcare providers, social service providers, and networks, then you're behind the 8 ball when it comes to being able to collaborate and partner effectively. Several years ago, HUD and HRSA did a project where we saw the importance of being able to have data sharing agreements just so you could tell who had received housing services, who needed them, who had fallen out of care. You know, we have data sharing agreements that allow sort of our AIDS drug assistance programs to say to community-based providers, so-and-so hasn't picked up their medication in 6 months, go find them. You know, but that can't happen unless you have that infrastructure, which includes those data sharing agreements.
All right, y'all. It is 1:02. We are out of time. I want to say thank you so much to Harold, Chrissy, Ben, and Maureen. Thank you so much for being generous with your time and sharing and updating us about the EHE plan and your role in it. And I want to thank you so much for your participation. There were some questions that we were not able to get to today. Would Zach be able to get to you and email you all with the questions and hopefully respond? Because some people like to see some of the reports that you were mentioning and referencing, the housing tool. I know people would like access to that. But yeah, I'll go ahead and wrap up and just say thank you so much to everyone watching on Facebook, joining us today. I hope you leave inspired and hope you have a great day. Thanks. Bye, everyone.